So this discussion is going to have us look further at applications of electrical stimulation, more specifically to neuromuscular stimulation and how we utilize it also with arthrogenic inhibition. And we're also going to talk about with this biofeedback. And biofeedback is not classically electrical stimulation. We'll talk about what biofeedback is and how we utilize it as far as rehabilitation is concerned. So when we look at neuromuscular control, so before we talk about how stim is used for neuromuscular purposes, we're going to look at the components of neuromuscular control. So there's basically three levels of neuromuscular control. There's volitional muscle contractions, there's reflex reactions, and then there's complex functional movements. So kind of breaking those down. So volitional muscle contraction is just, again, your voluntary ability to contract the muscle, okay? So it's just you being able to contract a single muscle. So if you were sitting, your ability to just contract your quadricep, say voluntarily. Reflex reactions goes up another level. So reflex reactions are kind of your body's ability to respond to situations. If you think about, if you've ever kind of took a funny step off of a sidewalk or something and your ankle kind of turned, but you were able to kind of get it back into position before you sprained it because your perineal muscles kicked in. That's an example of a reflex reaction, or just the ability to, like, for instance, maintain your balance. You slightly lose your balance, but you catch yourself. That's a reflex reaction. And then last, complex functional movements. That's where kind of things are tied into, more complex movement patterns. If you think of just what goes on in sports or just day-to-day activities, those patterns that come in. If you look, again, we talked about the whole rehabilitation hierarchy. There's, which is kind of reiterated at the beginning of the chapter again. You kind of see how all of this fits in. Again, kind of, at the base is the physical examination and the control of swelling, control of pain, and the restoration of integrity of the injured tissue. These things are up higher up on that list, but they lead to that return to activity. Arthrogenic muscle inhibition is something we're going to be coming back to. And that is when the ability of the muscle to contract is compromised due to a joint injury. So when joints get injured, the proprioceptors give bad feedback to the central nervous system, which kind of doesn't allow the muscles to contract the way they're supposed to. So it inhibits normal muscle activities, particularly even volitional muscle contractions. So your volitional muscle contractions are going to be affected by swelling, pain, and altered mechanoreceptor input coming from the joint. So when you have a joint injury and those mechanoreceptors get damaged inside the joint, the proprioceptors, that's going to negatively impact your ability to contract the muscles. So if we look at the impact on muscle contraction, so, swelling, if you think about it, if you get swelling inside a joint, what that's going to do is it's going to stimulate stretch receptors inside the joint, and that's going to trigger that reflex inhibition, okay? So that's going to be an important thing there. Pain, okay? So pain will contribute to deficits because, again, just the pain itself will kind of limit activity, and again, that's also going to kind of alter that input to the muscles that surround the joint. So again, that's going to impact what an individual is going to be able to do even with voluntary muscle contraction. So, and again, there's altered input, and that may just affect overall function. So one of the things we'll talk about later on, visual and EMG biofeedback can assist in reestablishing this. So we're going to talk about reestablishing neuromuscular control through both applying electrical stim and through the use of both visual and EMG feedback. So in other words, the person, in the case of EMG biofeedback, it's a device that actually gives the patient feedback on how much muscle contraction they're actually performing with this. So that's a different form, a different type of modality, if you will, but we're going to discuss how you can use that. So again, if you think about what we would be looking to do as far as different types of body part regions and things like that, we'd be looking at addressing specific issues as it relates to, different joints. So for instance, with the ankle, we always look to do progressive balance and coordination exercises when we have an ankle sprain. For the hip, hip pain tends to inhibit the glute max. So we know how important the glute max is. It's our strongest hip extensor. You get hip pain, that's going to inhibit that muscle. You look at the shoulder, neuromuscular control, the rotator cuff, and scapular stabilizers can affect someone's recovery from a shoulder injury. So it's really important to kind of make sure that an individual is able to carry out, exercise without pain and be able to get those normal firing patterns back. So muscle re-education, so a lot of different ways we look to re-educate muscles. Now, you possibly will need, I kind of led on to this in one of our earlier discussions, but if you have a muscle where there's no longer nerve innervation, either due to injury or chronic disease, you may need a long phase duration stimulation. So you might need a galvanic or special DC stimulator in order to do that. So that would not be a type of stimulation you would see with, for instance, what we use in class. You need a separate stimulator that would apply basically the same type of current that we use with ionophoresis, but it would be used instead of delivering medication to actually surpass the capacitance of the muscle tissue. Because remember, when you have denervated muscles, you actually have to surpass the capacitance of the muscle. You can't worry about the nerve because the nerve's not functioning. So you would need that. Now, in the case you have a muscle that still has, even though it might be, it might be inhibited a little bit or something like that, as long as there's still nerve innervation, you could use neuromuscular electrical stim, NMES, to address arthrogenic muscle inhibition after injury or surgery. So you could initially, it was initially developed to increase muscle strength, which it can augment muscle strength development. They don't recommend you use it just specifically for that without anything else. But we can use that as long as, again, the muscle still has nerve innervation. And it's contraindicated for unstable fractures. I talked about that when we went over the contraindications for STIM in general. PENS, or patterned electrical neuromuscular stimulation. This is a special type of stimulation. So what this does is it kind of goes through the agonist-antagonist pattern of normal firing patterns through functional activity. So again, that's a special type of stimulator that you would utilize. So you get the agonist to fire, the antagonist then would limit, and then you get the agonist to fire again. That would be a way you would utilize PENS, and we'll talk about some basic parameters for that later on in the discussion. So looking at muscle re-education, so first kind of examining the whole concept of muscle strengthening versus force capacity enhancement. So for a muscle to become stronger, you have to place a load on it and get adaptation to occur. So if you just think about like lifting weights, for instance, we lift weights because we're basically trying to place an overload on the muscle and increase the strength, okay? And that allows you to produce more force. Well, to just increase strength through electrical stimulation, it has to be as great as the overload would be for exercise. And what most research shows is that it requires at least 40 to 60% of maximum voluntary force in order to do that. That's usually not tolerated with neuromuscular stim. In other words, the neuromuscular stim you would have to apply to really increase strength would be almost intolerable to individuals. So really what you're more or less looking to do through NMES is to enhance the muscle's ability to contract, okay? There might be some residual strengthening that comes out of that, but really to improve strength, the best bet is just to do regular exercise. So now if the person can't do regular exercise because of an injury, then they have to use the electrical stimulation in order to kind of get that contraction ability back. So the actual function of NMES is actually just to enhance muscle contraction. If the person can do muscle contraction on their own and they can do strengthening exercises, then just do the strengthening exercises. However, for instance, in the case of, say, post-op ACL patients, they, one, have trouble getting their quadriceps to contract because the amount of effusion inside their knee, and they start to experience atrophy and disuse and everything else, and they're very limited with what we can do. So that's why we utilize in that, for that instance, the strengthening through electrical stim. So now when we look at endogenous versus exogenous contraction, so this just looks at, what we're looking at as far as an actual physiological contraction versus a contraction basically brought along by electrical stimulation. With NMES, the entire motor unit is stimulated to fatigue, okay, versus an endogenous or physiologic contraction, we recruit slow twitch muscle fibers first. So one of the things different between an endogenous versus an exogenous contraction is that slow twitch fibers, in other words, when you contract your muscles through exercise activities, your slow twitch fibers are always excited first. Fast twitch fibers come in when you need more forces is necessary. However, when you do an electrical stimulation, large diameter fast twitch fibers tend to are recruited first because they have a lower capacitance. So if the stimulation is increased slow twitch fibers, so the reversal actually happens. And then on the next slide, we'll just show you some other ways in which there's differences between the endogenous versus exogenous contractions. So here we see the differences between physiological and electrical muscle contraction. So the physiological is your endogenous contraction. That's what you do. The electrical stimulation is your exogenous, okay? So here we kind of look at what's the difference between the two. So you see the order of recruitment is different. The synchrony is different. So physiological, it's asynchronous firing to promote a continuous contraction. With electrical, it's synchronous, meaning they just all turn on, okay? Inhibition-wise, if the stimulation is strong, Golgi tendon organs will cause inhibition, which causes the muscle to relax. The GTO is excited with electrical stimulated muscle contraction, but inhibition of the alpha motor neuron is overcome because you're directly stimulating the nerve. So in other words, the alpha motor neuron doesn't shut off because it's not you voluntarily doing it. It's an outside electrical current that's causing the contraction to occur. Fatigue, there's minimal fatigue because of the order of unit recruitment and the asynchrony of firing with physiological, and with electrical, it fatigues rapidly because of how much fast twitch fiber recruitment there is. So your fast twitch fibers, while they could provide more force, they also fatigue much faster, okay? So these are the differences between the two. Now, in some ways, it's kind of good, particularly with the electrical muscle contraction. Fast twitch fibers do have the potential to atrophy much faster, and we know how important they are for a lot of activities, and especially for force production. So for injured individuals who can't produce a physiologic contraction, that's important to be able to limit the disuse of those fibers. So your parameters for NMES, typically if you're doing it for strengthening purposes or to enhance that muscle contraction a little bit more, for neuromuscular education, you're going to want to have a longer off time. So usually your duty cycle, now again here referring to the extrinsic duty cycle, you're going to want a 1 to 5 on to off time. What that's going to do is allow for your phosphocreatine stores, which are utilized for that, again, what we classically think of like short burst types of activities. It's going to allow for that to restore itself. You can progress to a shorter time, so maybe after a while progress them to a 1 to 3. That will kind of that will sort of allow for them to almost kind of condition the stores a little bit and kind of work on their capacity a little bit more, but always start with the longer off time. You want a high phase duration, your pulse rate. So here I'm saying 35 to 50. Some sources will say 35 to 70. Again, same basic idea. Most treatments usually fall in the 50. They usually just set it at 50 pulses per second for the treatment, but 35 to even upwards to 70 is okay. And the amplitude you just want, so there we're looking at the intensity. You want it to be strong yet tolerable contraction. It's still going to be uncomfortable for the patient. So that's kind of important to know that, and always tell the patient, it might feel a little uncomfortable, but you want to get a strong contraction. You don't want to make them so uncomfortable that during the entire time they're kind of like tensing up, themselves when they do it. The other thing is you want to encourage them to produce a contraction with the electrical stim, particularly post-operative knee patients. Try to get them to work on, as they feel the muscle starting to tense up, to try to do it voluntarily as well. That's going to help and enhance the process when they're doing it. So your types of neuromuscular stimulators, now remember, if you want, you can use any type of machine or waveform as long as it allows you to set an extrinsic duty cycle. So if you could set an extrinsic duty cycle, get a strong tetanus contraction, you could really use any type of stimulator you want. The Russian current is very popular to use, again, because you could set your you can set your parameters. There's preset parameters. You can produce a strong tetanus contraction. You always wanted to make sure that you, again, you want to make sure your phase durations, which with Russian stimulation, that's not a big deal. But if you're using another type of stimulator, make sure you could set a longer phase duration with this as well. If you do want, you can sometimes lower the frequency a little bit initially post-op. So I kind of gave the range of like 30 to 70. I know the slide said 30 to 50. Most people use 50. But you can lower the frequency sometimes initially post-op. That could sometimes make it a little easier for the person to get a contraction. And again, you want to just make sure you could set that on-off time. Again, you want a little bit of a longer off time initially, and then kind of over time you can reduce it. PENS, again, the pattern electrical neuromuscular stimulation. So what this basically is, it's an asymmetrical low voltage pulse current. So usually you have a 50 hertz pulse rate and a shorter phase duration. So the shorter phase duration, what that does is it allows the amount of discomfort to be less than what you get with normal neuromuscular electrical stimulation. So what that does is a person can actually go through functional movement patterns with this type of electrical stimulation on. With most neuromuscular electrical stimulators, it'd be a little harder to do that. But what you can actually do is, so you can still use the pulse rate and still get a pretty good tetanic contraction. The phase duration allows it to be a little more comfortable. And then what you can actually do is get that triphasic pattern. So the agonist and working the agonist and antagonist muscle groups as they would work related to functional activity. So this would be something that would be good, particularly as you advance the person a little bit more and want to get them a little closer to their sport-specific activity. So for instance, if you want it to with a shoulder, you could pattern the stim to work the agonist and antagonist muscles as it would, say, through like a throwing pattern. You'd be able to do something like that. So that's something important that you can utilize. And again, it would all be based upon the firing, and everything would all be based upon what they'd be doing activity-wise. And again, any type of NMES, again, biphasic TENS can be utilized for this. Anything where you can set a duty cycle for. If you have a machine you could set a duty cycle for with the wave. High volt, for instance, is another one. You can use high volt if you want it to. Just set all of the other parameters accordingly when you go to do that. So what you would want to do, again, and I kind of outlined this in lab, explain your treatment protocol to your patient. Again, encourage volitional contraction with the stimulation. It's going to be hard at first, particularly for post-operative patients, but you want to encourage them to do that as much as they can. And again, it's going to be uncomfortable for them. It's going to feel weird. But the more that they can do contraction on their own, the better off they'll be, and they'll get that ability to contract faster, and then they'll be able to just do regular strengthening exercises. Place the electrodes over the nerve and the muscle. So if you can get an area where the nerve's superficial and kind of then track the other one across the muscle, that's going to get kind of optimize your muscle contraction. So for instance, the quadricep is a very popular muscle to do this with. So they usually recommend trying to get it somewhere over the femoral nerve and then across to the VMO, and that usually produces a pretty good contraction. Position the joint at an optimal angle for muscle contraction. Now again, if you can do that, that's fine. Many times, again, particularly post-operative patients, you won't necessarily be able to do that. A lot of times they just start with their leg in extension because they don't really have range of motion. They might not even be able to get to 60 degrees in knee flexion. So they're not going to be able to do contraction from that point. So if it's not contraindicated or you can do it, that's fine. Otherwise, you have to kind of just work with what the patient is able to do. So here's kind of an example showing you what this looks like over the quadricep. So this is someone doing a short arc quad with the electrical stimulation on. So they're obviously here. They're not going to 60 degrees in knee flexion. They're just doing a short arc quad with it. Again, many times with your post-operative ACLs, they might not be able to do any sort of range of, active knee extension with the muscle contraction. They'll just be in a long sitting position and just getting the muscle to contract. And that would actually be to enhance some of their knee extension that they're actually missing. So that could kind of sort of complement that activity while they do that. So treatment of specific arthrogenic muscle inhibition. So this is kind of how you would do that. So for the inhibited muscle, you would apply neuromuscular electrical stim. Again, that'll help recruit motor neurons that are being inhibited. For the disinhibited muscle, what you would do is apply disinhibitory TENS, possibly in conjunction with therapeutic exercise. So what you'd actually do is apply TENS during the exercise and possibly use cryotherapy. So what you would actually be looking to do is, with this, is you'd be looking to disinhibit the issue as far as that's what's going on with arthrogenic muscle inhibition. So in addition to utilizing the NMES for the muscle, you could then apply these other modalities at the joint. So all of this would be done at the joint that's affected. So again, take the knee, okay? So if the knee is injured, the quad is inhibited, you would apply your neuromuscular electrical stimulation to the quad based upon the parameters. Then at the knee joint, you would be doing a disinhibitory TENS, which would be for pain relief, and even possibly using cryotherapy prior to. The idea is that you would decrease the inhibitory reflex and actually cause increased activation of the inhibited motor neurons. So in other words, you would actually then be able to further enhance that motor neuron recruitment by kind of working at the injured joint. All right, so we had discussed a little bit about denervated muscle. So this isn't something you're going to see a whole lot in more of your traditional sports medicine settings, because this is when the muscle basically has no nerve innervation, and usually this is going to be caused by either a major trauma or disease. So reinnervation, if it occurs, will occur slowly. So in other words, if someone does damage an alpha motor neuron and there's disrupted lower motor neuron behavior, that can regenerate, but it's very slow. So when you hear of people like severing peripheral nerves and stuff like that, it can come back, but it's very slow, and even when it does come back, a lot of times it's not the same. So if NMES fails to elicit a contraction, you have a lower motor neuron injury. You have a complete denervated muscle. In order to overcome that, you have to either use a low frequency or alternating or a direct current. So you have to use a current similar to ionophoresis. Now you can't use an ionophoresis unit to do it. You'd have to get another DC unit in order to do it. Because with this, again, as we said, the goal has to be to overcome the capacitance of the muscle. To overcome the capacitance of the muscle, you need that type of current because it's harder to stimulate that than it is just a an alpha motor neuron. So the capacitance of the muscle is higher than a regular alpha motor nerve. So an alpha motor nerve you can stimulate with NMES because it has a lower capacitance. You can't do that with a muscle. So in other words, when you're doing, for instance, Russian stim on someone's quadricep and their muscles contracting, their alpha motor neurons intact. They just may, either because of injury or for some other reason, they don't recruit all their fibers. They don't get a good strong contraction. So that's how the difference between the two types of stimulation are kind of differentiated. Okay, now we're going to look at something completely different. So we're looking at biofeedback, okay? And biofeedback uses instrumentation to bring awareness of muscular neural recruitment. So we're not actually applying electrical stimulation here, but what we're actually doing is, in the case of muscular biofeedback, we're actually getting feedback on the electrical activity of the muscle, okay? So we're actually taking electrical signals within the muscle contraction and converting it through a unit into audio or visual signals. And what that does is it gives the person feedback on how well they're contracting the muscle, okay? The precision and the timeliness of feedback are important. So these will be units that will actually tell the person how well their muscle contraction is working, okay? Another simple thing you can do, which is biofeedback, is just using a mirror to correct movement. So a person can actually see what they're doing and give themselves feedback as they're doing it. So this is basically a teaching aid for patients, whether you're just using like visual through the use of a mirror or something like that, or using an actual machine that gives audio or visual feedback in order to do that. So with an EMG, so when you're actually using a biofeedback machine, you have two active leads and a ground lead on the main pad. The signal from the muscular activity gets processed, and then the patient gets immediate feedback. So for instance, you might set the machine to a certain sensitivity. If the patient's able to exceed a certain level with that, a light will go off or a beeping noise will occur to give the patient feedback as to the type of activity they're getting. So biofeedback and volitional contraction. So this enhances recovery after activity. So again, and it gives the person feedback on what they're doing. It provides positive feedback. If someone's having difficulty contracting a muscle and they could see this visual feedback, it's going to encourage them to do it. Again, so that can be very good in regards to doing that. Now, you can typically use, there's two types of electrodes. I kind of talked about the other one, the surface electrodes. They also do have indwelling electrodes. So those are electrodes, they're a little bit more precise because they're actually needles that go into the muscle. So they're getting direct feedback from that. Now, clinically day to day, that's kind of not practical to use. You'd only use that, whether, if you're conducting research or possibly, doing more specific stuff with the biofeedback. So when you look at EMG, so EMG looks at teaching the person to regain their ability to contract the muscle, versus neuromuscular stim, which we talked about. That's used to kind of restart the motor efferent proprioceptive feedback loop. So it induces a contraction, and it doesn't take a long time to recover between, and it gives the person more afferent or sensory feedback, again, as opposed to the EMG, which just works on their ability to contract when they go and do it. So it kind of gives the individual some, the EMG, the biofeedback, is actually giving the individual feedback on how much active contraction they're actually performing. So take, for instance, someone with patellofemoral pain who maybe, has a little bit of a firing pattern problem or doesn't get their VMO to contract really well. You can put a biofeedback unit pad on their VMO, set the sensitivity. Now, for muscular contraction purposes, you want to set the sensitivity. Low because you want them to produce a strong contraction. And what that'll do is it'll force the person, so have the person contract their quad, or again maybe do a short arc quad, really trying to focus on that contraction. If they reach a certain threshold, it'll again either, again, all biofeedback units are a little bit different. I'll show you some of them that we have in class. It'll make a light go off. It'll make a beeping noise or something of that sort to show the person that they're getting their muscle to actually contract. So as we kind of move along, you want to eventually progress your responses. So again, go from just basic volitional muscle contraction to working the person through reflex responses. So again, balance training. Use a combination of open and closed chain exercises in order to do that. And then progress them to sport-specific functional activities. And you can actually perform functional activities with EMG biofeedback to enhance motor unit recruitment. So, again, it doesn't just have to be like sitting and just getting a muscle to contract and setting off the unit to do this. You can actually do this with like even adding it into their functional movement. So if you want to continue to carry that on, you can further enhance that. So here's a picture. So this is actually a biofeedback. There's different types of biofeedback units, and they show some other pictures in the book. I have some examples here I'm going to show. But here's an example of somebody doing biofeedback with the transverse abdominis muscle. You're also getting some imagery with this. So this one's a little bit more of a sophisticated one because it's also kind of showing an image of the muscle as well, but basically it's training the person to contract the deeper abdominal muscles, which sometimes individuals have a difficult time doing. Here's somebody using both a mirror for some visual biofeedback and using the EMG to do so. So as you look at this picture, you can see, so here's your pad. So you have your two active leads and your ground all on there. So this is right on her lower trap. So this is a common thing to do with like rotator cuff. People don't can get good contraction from their lower trap, which then they don't get good upward rotation. And here's the unit right here. So he sets the unit to a certain sensitivity. As she gets that muscle to contract, a little beep or a light will flash on this unit telling her that she's getting a good adequate contraction. The visual input, in all likelihood, what this person has some difficulty doing is they have difficulty elevating their shoulder without kind of hiking. So getting good contraction here will prevent that because you don't want the shoulder to hike while you're elevating your humerus. And that's what she's basically learning to do. So that's one application of this. As it relates to it, and again, the actual unit the ATC is holding is going to be what gives her the feedback there. But she's able to look at herself in the mirror to make sure that she's not kind of shrugging or hiking up her shoulder as she does this. Now, another thing you can do with EMG is you can actually teach relaxation. So as I said, you want to usually set a low sensitivity when you're trying to get the person to contract. What you can do in the case of somebody that maybe has some like tight musculature, particularly, you see this a lot of times in the upper trap and cervical region, you could set the sensitivity high and put it on the person, and then what you try to get them to do is through relaxation techniques, get them to get the muscle to relax. So in other words, now the EMG biofeedback is going to pick up on the increased activity in the muscle that's in spasm or tight, and the person's going to have to get themselves to relax, whether that's through, again, different types of relaxation techniques, the thought stopping, visual imagery, breathing exercises, even doing muscle contraction relaxation. In other words, get the muscles to tense and then try to relax them. That can help do that. So that can help break that cycle of stress, pain, and spasm. And this can actually be used in preparation for that as well. So if you're teaching it to get them to contract the muscle, you usually want to set a lower sensitivity. If you're looking to get them to relax, they have muscle tightness, spasm in a region, you can set the sensitivity high, get them to relax, okay? Again, but make sure if they have to use relaxation techniques, You want to make sure that you teach them, okay? Because not everyone's just going to know how to do that. So don't just assume that people will know. Yes, I know we all breathe, but don't just assume that someone's going to know how to do breathing exercises. You have to know how to teach that so that they can get them to relax. So that's really like the biggest setting thing as it relates to biofeedback. It depends on if your goal is to get them to get feedback on muscular contraction or if you want them to get relaxation. For contraction, set the sensitivity low. And again, there's ranges of low. You don't want to set it so low that they're not getting any feedback early on, because early on when they're using it, it's going to be harder for them to get the muscle to contract. So set it low, but don't set it so low that they're not getting any feedback. But relatively speaking, you want to have a lower setting. Set the sensitivity high if they have to learn how to relax. So just in summary, so electrical stimulation can artificially produce a muscle contraction. Again, it's a different type of contraction, so make sure you know the differences between all of them. Biofeedback brings conscious awareness to muscle contraction. So whether you want them to contract or you're trying to get relaxation, either way, it's bringing conscious awareness to muscle contraction. And the biofeedback can help restore all three levels of neuromuscular control. And then you just have your learning outcomes.